So the problem here is that people have withdrawal symptoms, and the next 2 pages are those. So whenever you're taking somebody off of one of these antidepressants, it's best to taper it over a couple of weeks. So the symptoms, now fluoxetine is the exception here because it's so long-acting and its metabolite is long-acting. Usually the withdrawal symptoms are the risk is low. So Paxil would be the worst because it's the shortest. So the type of symptoms would be sensory symptoms. So you see the paresthesias, numbness, describing a rushing noise in the head, or the palinopsia, the trailing, visual trailing, kind of a cool, not for them, but disequilibrium, so the lightheadedness, dizziness, and vertigo. You can see where some of these would be interpreted due to other things or dismissed by the patient. It's the cluster of them together. Somatic symptoms, so decreased energy, headache, tremor, sweating, anorexia. Some of these might look like their depression's getting worse. Affective symptoms, increase in irritability, agitation, depressed mood, tearfulness. GI symptoms, nausea, vomiting, diarrhea, and sleep disturbances. Nightmares, excessive dreaming, insomnia. So here's a mnemonic for discontinuation of symptoms. So a flu-like symptoms, kind of generalized malaise, achiness, insomnia, nausea, imbalance, sensory disturbances like that palinopsia, and then hyperarousal. So maybe something to keep in mind. Warn patients. Warn them, let them know this could happen. Here's what could happen. And so they can tell you. Now, this could happen because they quit the medicine, they don't like it. Could be that they run out of medicine and they don't get to the pharmacy. Run out of medicine, don't have the money to pay for it. Okay? Lots of different issues. Go on vacation and forget to take their medicines. I can't tell you how often I hear that. I went on vacation, I forgot to take my medicines. Okay? Some, I think they would like a vacation from their disease. I mean, and who wouldn't? Okay, so there's your reminder about, on top of 15, about half-life influence here. So that's the SSRIs. Moving on to the SNRIs. There's an old group and then there's the newer group. So the older group are where the TCAs, the tricyclic antidepressants fit, like amitriptyline. Others are listed there. Imipramine, doxepin, nortriptyline, dizipramine. They're all generics at this point. Older products have probably been around 50 years, 40 to 50 years. No longer used, mostly because of their side effect profile and their lethality in overdose situations. So back then we would never fill a prescription enough that patients could take a lethal dose. So what patients can do is they'll hoard them. If they're gonna, that's how they're planning to commit suicide, they'll save enough until they get enough to do that. So these drugs work on 2 of the neurotransmitters, norepinephrine and serotonin. What you're going to see with the newer agents is that they may at lower levels affect one of the neurotransmitters, and at higher doses they have dual action. Usually they will have a preponderance, much more effect on serotonin, little effect on norepinephrine. What we'll see with malsaprin is that it's mostly norepinephrine and very little serotonin. So this class is very diverse. Even though they come under this general heading, they are not all alike. They have a lot of dissimilar effects. So with the older agents, they affected a lot of the different receptors. So here you would see anticholinergic side effects. So tricyclics tend to have a lot of anticholinergics. So dry mouth would be very common. Sedation, very common, and we use that to our advantage. So sometimes like when we get to diabetic neuropathy, this is a great drug for it because it affects substance speed, decreases neuropathic pain. Take it at night, and you get a better sleep. So we use some of those to our advantage. Adrenergic side effects. So this would be mostly on the cardiovascular system. Blood pressure is one of the big effects. cardiac conduction delays. So that is some of the problems you get into in overdose situations. AV block, severe arrhythmias. Going down to the newer agents, so venlafaxine, desvenlafaxine, that's the active metabolite. Duloxetine, we've talked about Cymbalta before. Levomilnacipran, that's, and milnacipran, so levo is the enantiomer of milnacipran. So mechanism of action. So venlafaxine, and if you look at the next 2 or 3 pages, there's pictures that show you the receptor effect on norepinephrine or adrenergic and serotonergic receptors. So venlafaxine is serotonin at low doses, dual action at higher doses. Its effects on serotonin are much, much higher than what you get with norepinephrine, about 5-fold. Milnacipran is much, much more effect on norepinephrine than it is on serotonin, about 3-fold. Duloxetine is kind of a middle of the road, very well tolerated. We use it for lots of different things, both serotonin and norepinephrine. So the affinities for those receptors are listed there in the next little section. So serotonin over norepinephrine, desvenlafaxine, venlafaxine, duloxetine. Preferential are pretty much the milnacipran and the levomilnacipran. So kinetics. These are both duloxetine, a potent inhibitor of 2D6. Lots of the psychotropics get metabolized through that pathway. So they tend to affect each other if you're treating multiple psychiatric problems with different drugs. They are contraindicated in patients who've had MAOIs. I'm going to skip these pictures. They're pretty much giving you a picture story of what we have just talked about in terms of the serotonin and norepinephrine. The little pluses show you the strength of the inhibition on those different receptors. On page 17, it shows you the dose response with venlafaxine. Low dose, mostly serotonergic. Higher dose, you get both. Desvenlafaxine doesn't seem to have a preference, so it's more even. So you can use this kind of information in terms of moving from one drug to another. Patient can't tolerate serotonergic effects, then you know you've got some that are much less serotonergic, more like a norepinephrine. Somebody's got cardiovascular effects, you can't use an SSRI, which one do you go to in the SNRIs? That's how you use that kind of information. And if you were able to do that, then my little pride for you would just go out the roof. On page 18, there is another example of the different dosing. Again, use it for your case discussion. Let me walk you through just the top so you'll see some of the things that are different here. So with venlafaxine, you've got initial dosing, and then you have when you can increase it. So there you see it, this one, they say after 4 days, increase the dose. Manufacturer or guideline maximum doses will be in that other column. I'm not going to ask you max doses. There's a lot of, not controversy, but you'll see different information. Manufacturer may say this is the max dose, and in clinical trials they may say you can go on up to a higher dose. Or doses in the mid-range, there's nothing effective beyond that. So as people have more experience and there's more studies that come out, sometimes those maximum doses for the manufacturer is based on the information they submit to the FDA and what the FDA approved. So the manufacturer can't say anything beyond that. They are bound by what the FDA has limited them to. Now, the drug studies aren't limited by that. So that's where you'll see discrepancies. When we get to the schizophrenic drugs, we'll see even more of that. So that's why I want you to know, because you'll read it in the package insert, here's the max, but then you'll see someone else using beyond that. most of the time for depression, beyond the max dose does not give you more effect or better results. Adverse effects for the SNRIs. GI is probably one of the most common. Again, related to the serotonin. So look at venlafaxine extended release, lower incidence of nausea during the first few weeks of therapy. So that might be something you could use to your advantage. But the most common reason for the desvenlafaxine is the nausea. So they're really different. And that one is true. You really get sick to their stomach without the drug. On page 19, blood pressure changes. If you're affecting norepinephrine, your blood pressure is going to be affected. So since you're increasing the amount of norepinephrine, you have adrenergic receptors that can interact with it, then blood pressure will go up. In this group, duloxetine seems to be the more neutral of the agents. Sexual dysfunction, same problem we saw with the SSRIs. The venlafaxine extended release has a higher rate of sexual dysfunction among men compared to the immediate release. In desvenlafaxine, less sexual dysfunction than the other serotonergic drugs. So if you're using these classes a lot, you'll start to appreciate that. So in your history, or when you see people back and they're complaining about certain side effects, then you'll know that there are others. Even if you can't remember, you can know there are drugs that have less impact, and you can look those up or go after them. Levomilnacipran and milnacipran, those are, if you've got hypertension as a problem, don't avoid those because they're predominantly norepinephrine. Don't use them in end-stage renal function, glaucoma, urinary hesitancy, but they're weight neutral. So if you have someone who doesn't have, you're dealing with a younger person, doesn't have cardiovascular, and weight is a problem, this might be one to think about. See how you use all those? All right. Venlafaxine will increase anticoagulant. I would probably assume you're going to get an interaction until you can look up and find different when you're looking at bleeding time with the SSRIs and SNRIs. They're also on the Beers list in terms of SIADH is also a potential problem with the SNRIs. Next page, 20, gives you a little picture to look at serotonin effect, gives you these side effects, norepinephrine gives you these side effects. Now coming down to the maybe the less common is the norepinephrine and dopamine, another neurotransmitter. Okay, so this is bupropion. We talked about it with smoking cessation. So the drug that it's marketed for smoking cessation is Zyban. So very unique because you got that dopamine, but they also have an affinity for nicotine receptors. So they decrease the nicotine withdrawal in patients who are trying to stop. I think you had this one as one of your prescriptions. Remember, it came as a pack you had to set a. We also did Chantix this way. You have to set a quit date. You start the drug ahead of time. You work it up to a certain point, and then you want the person to stop smoking. So usually you start about a week before in smoking cessation. So a couple of things with this one, and draw a circle around it. It's an augmenting agent, so you can add it to other antidepressants to augment. Let's say you're getting some response out of a drug. Maybe the side effects are a problem, or you can't increase the dose any further. So this one you can add on. It also does not cause sexual dysfunction, so it might be one to use if you're having that problem and it's impacting adherence. It doesn't have any anticholinergic, or antihistamine, or hypotensive. Beautiful. Okay, so kind of a purist in that sense. It has 3 active metabolites, which means it has a very long duration of action. Side effects are important. It is big on insomnia. You can't give this, it's usually a twice-a-day drug. You can't give that second dose very late in the day because they will not be able to get to sleep. So it's kind of activating. So usually 8 o'clock, 2 o'clock in the afternoon. I usually didn't give it much past 2 o'clock. But I was dealing with a bunch of older, well, not always older, but people who went to bed early. So depending on if they want to stay until 2 o'clock in the morning, then the drug probably won't bother them if they take it later in the day. The other is seizures. This drug lowers the seizure threshold. So people who are prone to seizures, or if they are on drugs that are also lower seizure threshold, this drug will increase that risk. It's also a dose related, so it has a maximum dose of 300 milligrams a day. I don't think I put it on there. So the other side effects are fairly low. Dry mouth, dizziness, anxiety, tremors, much lower incidence. Contraindication, eating disorders. If they've got bulimia or anorexia, don't use these. It'll make it worse. The monoamine oxidase, I would say just err on the side of don't use these drugs ever with any of these with MAOIs, and always have a washout period. Seizure disorder we talked about. Withdrawal is a problem, especially if they've got alcohol, benzodiazepines, other sedatives can make it worse. The next page is, again, pictures that are going to tell you or illustrate the same thing we've just talked about those. So going over to page 22. So here's another atypical. So bupropion is called an atypical because it's not serotonin or norepinephrine. This one is another atypical, serotonin and alpha adrenergic antagonist. This is mirtazapine or Remeron. So it also works on presynaptic alpha 2 adrenergic receptors, central action. Lowering anxiety, it does have activity on histamine receptors, so it will cause us sedation, so that may be to your advantage. Dosing schedule, note it's given at night because of that sedation and titrated every 1 to 2 weeks, up to 45 milligrams a day. Again, I'm not going to ask you those specific, just note the pattern. Adverse effects, weight gain, problem. Dry mouth and drowsiness, or interfere or nuisance complaints. But it doesn't increase sexual dysfunction. So this may be an alternative to someone who cannot tolerate SSRI or an SNRI. It's not an augmenting agent, it would be a replacement agent. Doesn't have effect on blood pressure, it's neutral. Rare is agranulocytosis and neutropenia, but it's so rare that there is no recommendation for monitoring or screening. Okay, questions about those? 2 atypicals, different neurotransmitters. One's an augmenter, one's a replacer. It would be rare that you would start with those agents. It would be either past effect. So often in your history, when you are talking to somebody who's got a history of depression, you ask them, what has worked in the past? It is not inappropriate to start back with that same product. So if they gave you a history of good response to Remeron, that might be a reason to restart it or reuse it. Okay, the monoamine oxidase inhibitors, phenelzine, Nardil, selegiline, MSAM, that is a patch, and then tranylcypromine, Parnate. These are old agents. Parnate and Nardil have been around for decades. And they are going to increase all of the neurotransmitters that are effectively enzymatically cleaved by them. So norepinephrine, serotonin, dopamine. If you look down through the table below, let me go back up. Phenelzine and parnate are non-selective. They will hit monoamine oxidase A and B. Selegiline does the same. Remember we talked about selegiline with Parkinsonism because we use it for its MAO-B inhibition. So in this one, here with phenelzine, you can rapidly titrate it from 60 to 90 a day. Clinical response can take some time. Takes some time for it to go away, takes some time for it to be fully apparent. Again, selegiline is a patch, so you can titrate it up to the maximum that's listed there. Okay, questions about those? All right, side effects on 23. Big thing is postural hypotension. Dopamine's in there. Remember we talked about dopamine agonist and levodopa. What was the big thing? Orthostatic hypotension. Okay, so bring those things over when you can kind of go back and reinforce what you've already learned. Other side effects: weight gain, sexual dysfunction. Phenelzine is a sedative, more sedating. Tranylcypromine is a stimulant. Now look what it can cause: insomnia, fever, myoclonic jerking, wrist deep tendon reflexes. Hypertensive crisis when you eat drugs or eat foods that are high in tyramine with this drug. So you would always, always give them a list and say, avoid these foods. Okay. I could never take these drugs because coffee and chocolate are my two basic food groups that I have every day. I just could not give them up. Okay, so tyramine has effects on blood pressure. Most of the time, we can metabolize it pretty quickly, but if you're using this drug, then you can't metabolize it. And so the amount of tyramine goes up in your system and it raises blood pressure. So that's the problem with tyramine and eating a lot of these foods. This is not an exhaustive list. This is kind of the highest ones. This is some to give you an example. One of your objectives lists certain foods for you to know. I can guarantee I will ask you because it is a very life-threatening if you do not warn patients. So looking down through their cheeses, so think cheese, beers, sardines, canned food, aged meats, liver. How many of you like liver? Anybody like liver?
My mom.
Love liver.
You eat it with syrup?
No.
We do with syrup.
No. But my grandmother could cook liver that anybody could eat. It was so good. And chicken gizzards and chicken livers.
If I see any of those things in our house, I'm throwing Untitled Chapter. So Schultz can have all of it. I've never.
When we go to Nicks and the Sticks in Tuscaloosa, I always order chicken livers. Oh, so good. They're good cold. They are good hot.
The only reason you can eat chicken livers at Nick's is because you get one of those Nicodemuses. It's a drink kind of like a hurricane. They only serve two in a styrofoam cup. Otherwise, you are a DUI in the bacon.
And it's telling. It's really telling because the police park there's always a policeman about 2 blocks down on either side from Nicks and the Sticks waiting for the people to come out. It's redneck Alabama. I mean, what can you say?
And if y'all will go Google criminal records, that will explain your DUI.
I do not.
I want to check them out.
Oh, goodness.
That's what you get for calling down with a redneck.
Okay. Serotonin modulators. These are not very commonly used. Nifazodone and Trazadone are old agents. They were actually, after the tricyclics, these were kind of the next agents that came out. They were called tetracyclines. Trazadone now is rarely used as an antidepressant, but it's used a lot for its sedative properties. It'll put you to sleep. So often they'll give Trazadone at bedtime and they'll use a different drug during the day. So not a very powerful antidepressant, but still around, mostly used for that. The other two are I don't even know how to say it. Vilazodone and Voroxetine. Okay, so they are serotonin. Trazodone has a little bit different effect, and you can see it's a histamine receptor. That's where that sedation. It's fairly powerful. Adverse effects I've listed down there for you. Somnolence with Trazodone, dry mouth, that's the histamine effect. There's not really anything new there. I will tell you for the most part, I want you to know these agents, what they are and what they belong to. I probably won't ask you a lot about them. But keep them in mind as a different group that you could go to if you can't use any of the others.
Untitled has a TV commercial. It's on all the time.
They do.
I haven't seen the one for Vibrant. Very often, but
Vibrant.
yeah, Vibrant.
Okay, next page and a half is a table of the side effects. I will hold you to these, I mean, you got to know the side effects. Okay, so that's an important piece. Page 25, summary of uncomplicated major depressive disorders. SSRI, drug of choice. Patient responds or goes into remission, that's what we're hoping for. We're going to treat them for at least 4 to 9 months. We're going to consider longer, up to 3 years as maintenance. Patient has a partial response, then we're going to, and the drug is working, but not to the extent we want. We can use an augmenter, that's the Bupropion. Or you can switch to a different agent, SSRI, or an atypical like mirtazapine. If the patient doesn't respond, adherence, adherence, adherence. I don't care what disease you're talking about. If they're not responding like you want, you have got to find out how are you taking the drug. Okay? It's just so common. I just assume it. I just assume people don't take the drug like they're supposed to. It's hard for people to be 100% adherent. Okay? So ensure medication adherence. Switch to an alternative. Maybe find out why are you non-adherent. Side effects would be big. One is that the drug doesn't live up to its potential. One is that they were put on the drug and not really anybody explained it. I can't tell you how many times we would get patients and I'd say, okay, I see from your chart that they started you on X drug when they saw you. How's it going? Oh, I never filled it. Common. Why didn't you do it? I just didn't believe them. I just don't think I need it. So all kinds of things. Usually the less they understand and know why you're doing something, the more likely they are to take it. Maybe they couldn't afford it. Maybe they went to the pharmacy and pharmacy said, it won't go through with your insurance. Now it's $360 that you can pay for. So there's all kinds of reasons. So always, always seek out a barrier as why are people not taking the drug so that you can address it. Some are easy fixes, some are not. Remember, 3 to 4 weeks is required before mood-elevating response is seen. 6-week maximum trial, 6-week trial at maximum doses before you consider it a drug that won't work. Talk to them about the lag time. Give them the time frame. Schedule appropriate follow-ups. Elderly, use lower doses. Washout periods for MAOIs, either coming or going. Okay? All right, so that's kind of summary. Resistant patients, again, inadequate therapy, not taking the drug, didn't respond, didn't take it. So change the dose, augment, add psychotherapy. That may be a missing piece. It is rare to use 2 antidepressants. Okay. So switching classes and adding other things would be important. Okay, any questions over depression? Serotonin syndrome. So all of these drugs have the potential to cause serotonin syndrome. It's a life-threatening syndrome, so it's important to be aware of it. So unlike anything else you have, there's one criteria. Have you taken a drug that affects serotonin or not? If they haven't, it's not serotonin syndrome. Easy. Don't you wish they were all like that? Okay. If they've had a history of taking a serotonergic agent, then the symptoms that are common are usually going to be that of muscle activity, increased muscle activity, clonus would be important. Or agitation is very common. Sometimes, and agitation will add to the muscle problem. They usually lose autonomic control. So blood pressure goes up, they're diaphoretic, they get very agitated, and difficult to deal with. Also temperature control. So that's the cluster. Patients may present with all or just one or two of those symptoms. If you look on the next page, this is the differential in that box. The second one down is serotonin syndrome. So you can, we haven't talked about neuroleptic malignant syndrome. Malignant hyperthermia we hit with the dopamine. Remember when the patients stopped abruptly their dopamine? Okay. So serotonin syndrome, muscle tone rigid, mucous membranes wet, pupils dilate, vowel sounds increased, reflexes increase. Almost everything goes up. Got to stop the serotonergic agent. Supportive care is mostly what is happening. If it's a mild reaction, that's usually all that will be required. Sedatives with benzodiazepines are meant to calm their agitation and that muscle, get the muscle activity down and relax them. Okay, so that's mild cases. Moderate cases, that's when that autonomic instability, so blood pressure, heart rate, diaphoresis, and temperature. The more hypothermic the patients are, they probably are going to have to be in more critical care. And then again, it goes to more supportive care. So oxygen, volume, cardiac monitoring, correction of vital signs, sedation with benzodiazepine. The biggest thing is recognize it and get them to help. Okay? Make sure they understand what that looks like. It's usually multiple uses. Usually one drug by itself is not usually the main cause. It's when you start adding multiple drugs that affect serotonin. And some drugs affect serotonin that we don't think about. A couple that we've talked about in here, one is the cough syrup, dextromethorphan, tramadol, a pain medicine. They usually will come up as problems on when the patient tries to fill them. But if they're taking an SSRI and you prescribe tramadol, that can increase it. Or they're on SSRI and they do it over the counter with dextromethorphan. So increasing serotonergic drug types, different sources. Okay, that's usually the common. On the last page, management of autonomic instability. This is more severe patients. So severe hypertension, tachycardia can be taken care of by esmolol. That's an IV beta blocker. Yes.
So with the serotonin syndrome and you're discontinuing the medication, are you still worried about withdrawal symptoms?
No, not at this point. Good question though. Nitroprusside, did you all talk about nitroprusside in cardiology?
I think we did. We mentioned it under the nitroprusside, but it was just like a tidbit.
Very powerful drug, very quick acting, short acting, on and off, very quick, very powerful. If they're hypotensive, then you can use sympathomimetics like epinephrine or norepinephrine would be used. Control of hyperthermia, one is to sedate them and get that muscle activity down, will help. So sometimes they will use a paralytic agent, or they will intubate them as well. If benzodiazepines don't work, you can always try cyproheptadine. It's an anticholinergic agent. Can be given on every 2 hours. Let's see, it does have a max. No. Initial dose is 12, followed by 2 every 2. These are going to be ICU or ER. Questions? All right. Let's go to bipolar disorder. So tell me what you know about bipolar disorder. 2 different types. Okay, what's type 1? More severe mania and depression. And what's type 2? Hypomania or acute or mania. So they can also have mania, right? But the more extreme is type 1? Okay. All right, so our goal of treatment is remission and resolve the psychosis. If we can't remit, get all the symptoms away, the mood symptoms, then we're going to look for response. So stabilizing the response so the patient is safe and can function, functionality, not a harm to themselves, others, and are not exhibiting behaviors that are going to cause them financial harm or physical harm, psychological harm. We want to prevent other episodes. We want to maintain good functioning. And adherence, that's a hard one. And adverse effects. Did he show you a picture of someone who's in a Mnemonic?
Yeah.
They are impressive to talk to. Drug classes, so these are really different. Here are the drug classes we use. Lithium, anticonvulsants, mostly valproic acid and carbamazepine, and lamotrigine. The antipsychotics, and almost always we use the 2nd generation antipsychotics, but we may use Haldol, which is a 1st generation. And then the benzodiazepines. The mainstay are lithium, valproic acid, or lamotrigine, and the 2nd generation antipsychotics. Those are really your mainstays. Benzodiazepines are often, they are not usually done for the mania. They are usually going to treat the symptoms of like insomnia, agitation, anxiety. General approach to therapy, we're going to individualize. A lot of it will be based on past history, side effects, other drugs they're on, other comorbid diseases, because lithium is a great drug, but it has lots of toxicity, a lot of side effects. Adherence is, so this is lifelong treatment, and going with adherence, a drug that a person can tolerate for long periods of time, is important. Most of these drugs carry some type of problem long term, especially lithium. So the patient, we want them to stay on a mood stabilizer the rest of their life. So that's usually a lithium or an anticonvulsant, usually valproic acid. For the depressive episodes, we're going to use antidepressants, but in acute situations, we're going to take them off because they tend to make things worse. Okay. Nonpharmacologic. So a lot of it is sleeping well, eating well, exercising, doing the things that maintain health are good adjuncts. Counseling, not only of the patient but of the family, and education, family therapy, understanding behavior and how to deal with it, how to keep a family functional. Okay, so pharmacologic therapy, we'll start with hypomania and mild to moderate, and then we'll move to, we'll say a little bit about severe mania. So here we have mania, but we have an absence of suicidal, homicidal, aggressive, or psychotic features. Most of these patients can be handled with monotherapy, so one drug, usually. Often they may go acutely to a second-generation antipsychotic. And the two that have the most data behind them are risperidone and olanzapine. So risperidol and Zyprexa. I'm not going to say much about mechanisms and all that, because this afternoon we're going to talk a lot about the second-generation agents. Alternatives, and these are all based on data from clinical studies. So there's quite a few of them. This is the majority of the second generation. So Abilify, Sapphirus, Vraylar, Invega. As I was going through these, I thought, okay, Bethany, do these not strike you as science fiction names? I mean, Vraylar, I figure the people who made these names have got to be Star Trek fans. Vraylar, Invega, Sapphirus, Geodon.
I think they probably get people with schizophrenia or bipolar and ask them to give names.
Probably.
They're kind of out there.
Probably.
Don't underestimate drug companies. I will guarantee you they talk to patients about the names. They do. It's attractive. It's sexy.
The anticonvulsants, again, valproic acid or valproate is probably much more common than carbamazepine. The other would be lithium and then Haldol, first generation. So with resistant, they will often use combinations: lithium, second generation antipsychotic, valproic acid, and a second generation antipsychotic. Often, whatever drug worked to calm them down, they will often continue in the maintenance therapy. Okay? If the side effect profile is not a problem for that patient. I guess he thought I could handle it for me. The benzodiazepines are really if you cannot use any of the other drugs. So clonazepam and lorazepam, so Klonopin and Ativan. So benzodiazepines, more of last resort because they're addiction potential and they're not as good. They're just not as treatment-wise, they're not as robust. So page 3. So if you've got acute mania, here are some things to think about. You want your psychiatric history, because number one is if they've been off medicines and they've had something that's worked before, you want to use that, you can use that again. You want to know what other psychiatric illnesses am I dealing with? Have you stopped all your medicines? And so that will help you in terms of restarting or knowing what to pick. You want to do a mental status exam because it could be due to another disease that they have, substance abuse, and so and your drugs can help with stabilizing that. You want to look at their risk of suicide because some drugs are going to make their suicide risk potential higher. Aggressiveness, violence to others, the catatonia. Did he show you pictures of catatonic patients? Have you seen those yet? Assess secondary causes of mania or mixed states. So alcohol, illicit drug use. Those would be really important. Increased caffeine. They're drinking Red Bulls like by the gallon. Their medical history, a physical exam, laboratory. So if you suspect substance abuse, you're going to do a urine screen for other drugs. You want to know if they had drugs that prescribed and they're not taking them, or are they overusing them. Then some of these you can draw blood levels, right? Valproic acid, carbamazepine, you can draw a level. Lithium, you can draw a level. You can tell whether they're toxic. Lithium toxicity often will look like a manic attack. So you could verify whether or not they're taking the drug or they're having toxicity. Renal impairment, liver disease. So some of these drugs renally cleared if they had an acute renal failure on top of maybe renal insufficiency, then they're going to be toxic. So here's an example. When we would see folks with lots of mental disorders down in the VA and the clinics that we worked in, if we ever had a patient who came in that looked like they were decompensating, if we sent them to psychiatry right away, they would refuse them. They said, first of all, internal medicine sees them, works them up, makes sure there's nothing organically causing the problem, then we'll see them. So that was kind of the process that we had to go through. Same things here. Is there something, if it's an acute mania, did something happen to them? They do something to themselves? Has another disease or condition worsened, cause them to be toxic on the drug? So that is really an important part. A lot of times you can resolve it through those avenues rather than having to go straight to a psychiatric solution. Acute on chronic, if they're not taking their drug, common reason for decompensating. So optimized therapy, getting them up to a therapeutic range. So it's good when you have drugs like lithium or valproic acid that you've got a target. They tend to use the same targets for valproic acid that they do for anticonvulsants. Do you remember what that is? What is the therapeutic range for valproic acid? Okay, so they'll use the same things. What is it for carbamazepine? 4 to 12. Very good. If they're on an antidepressant, stop it, and you can stop it abruptly because it can be worsening their mania. Discontinue drugs of abuse. Reduce, get rid of the alcohol. Taper off stimulants, caffeines, nicotine, if possible. And then encourage good nutrition and good body treatment. So if they're on a mood stabilizer, optimizing that would be the first choice. Restarting it or increasing the dose, those would be important. If they are first time, then initiating a mood stabilizer. So using the second generation antipsychotics to calm them down, putting them on lithium or valproic acid to stabilize mood. So again, your three are lithium, valproic acids, second generation antipsychotic. And if those singly don't work, use them in combination. It is rare that you would see lithium and valproic acid and an antipsychotic. Usually it's lithium and a second generation valproic acid second generation. Severe mania are almost always going to be treated off the get-go with 2 drugs. Okay, so lithium, second generation agent, valproic acid, second generation agent. Maintenance therapy. Usually you're going to continue the same regimen that you were able to stabilize them on. So there's studies that support this. So this one was one that looked at about 150 patients who were on valproic acid. And then they were assigned to maintenance with either divalproex or lithium. And they looked at time to occurrence compared to placebo, and they found that those who were started on the valproic acid had longer to recurrence than even lithium, which is an effective drug, but they did not have they had a decreased time to recurrence. So all that's saying is that if a drug works to stabilize them and get them under control, continue it, because they're usually the response rate. Response rates are going to be looked at as symptom response. You're also going to look at how long till the next time they relapse. Okay? So the goal is always to keep spreading that out. Hopefully they'll never relapse again, but usually it's common that they will. Okay, next page, second line. So second line usually would be switching to a different second generation antipsychotic. So using one with a different profile, different adverse effect profile would help. The other is adding lithium. So these drugs are considered second line if they weren't used as first line. So lithium, valproate, quetiapine, or Seroquel, and lamotrigine. Quetiapine is in there because it's got evidence behind it. So let's look at these. Lithium is really effective. It decreases relapse potential and suicide potential in about 30% of patients. Valproate decreases relapse by about 30%, about the same. Side effects I've listed for valproate, but I'm going to refer you back to your seizure handouts because I did a much more thorough job there. Side effect profile is the same for in mania as it was for seizures. Quetiapine or Seroquel increases time to recurrence, so stretches it out further, decreases number of relapse. Can be used in combination, so that makes it useful. Lamotrigine Lamictal is one of the more atypical anti-seizure medicines that we talked about. Very well tolerated. Now you'll look at it reduces risk of relapse by about 16%, so it isn't as impactful as lithium or valproic acid, but much better tolerated. Fewer drug interactions. So what was the big problem with lamotrigine? Do you remember the big, pardon? Rash, Stephen Johnson. So remember, and that was usually more problematic when it was used in combination with what? Valproic acid. Third line agents are because you don't have the evidence. So olanzapine is one of them, Zyprexa. Or poorly tolerated. Weight gain, very high with this category, and increased risk with type 2. Others that fall into this category, Abilify, Respirators, Zyprexa. Again, it all goes to what evidence or what studies are behind it. All of these agents most of them they all come as orals. Some of them come as injectables. So sometimes if you can't get an oral, or if you want a long term, usually they're given every 2 to 4 weeks. Patients who relapse frequently. Using combination products is important. The 3 or 4 that have been looked at in drug trials are Quetiapine, Respirators, Zyprexa, Abilify. If you look down through this chart, you'll see a difference than you saw with the antidepressants. You titrate these drugs very fast. Let's see which one is like that. Look at Quetiapine, Seroquel, it's down towards the bottom. For the immediate release, you start with 50 milligrams at bedtime day 1, 100 milligrams day 2, 200 milligrams day 3, 300 milligrams day 4. Very rapid titration. Don't do that with the antidepressants. Some of them have IM, so you can use that. Some people feel that improves adherence, only if the patient shows up for the injection. So that's a problem with the longer acting. Some of them like, is it on here? Yes, look at Saffris. Saffris is interesting. It only comes as a sublingual. So if you got somebody who can't take oral pills, then you could look at it. Most of them will come, or if they're coming a regular release, they also have an extended release. So sometimes those help with side effects as well. Okay, let me show you on page 6. This is Abilify MySide technology. This is really cool. Mostly I'm telling you about it because of the coolness factor. So because adherence is such a problem, this has been developed. This Abilify tablet has an internal sensor in it. So when you ingest the drug, you also have the patient put a patch on. And the drug, when it's ingested and dissolves in the stomach, will send a message to the patch. The patch then communicates with an app. So they download an app, they put on a patch, the patch stays in place for about 7 days, and it will collect the data, when the person took the drug and how often they took it. And then that information can be communicated with a healthcare provider if the patient chooses to share that. So this technology is only, I don't even know if they've released it nationwide. It was approved last November, and it was going to go out to special areas. So I don't know if it's widespread use. It'll be dispensed through specialty pharmacies. So anyway, more and more of this technology is going to come out. So what do you think about that? Did you ever read George Orwell's 1984? That's what I think, Big Brother.
But it seems like the patients who are not going to take their medications are going to just do it. Like the patients who are going to take it all the time are more like, so it doesn't seem like
Possible. What else do you think about it?
You can see it for elderly patients. My grandma, for example, was the worst at taking her medicine at certain times. So they had an app that had a schedule, and then would monitor, oh, I actually took this or I didn't.
So think about it from a provider standpoint, and then we'll look at the patient side.
I think it caused more frustration.
Pardon?
It caused more frustration.
Why is that?
Well, I mean, if they lie to you, that's one thing. Saying, yeah, I take it and it's not working, but now you know they're not taking it, so now you know they're lying to you, you know they're not adherent, and there's really, I mean, you can't sit there and force them to take a pill every day. You can't hold their hand and say, okay, take this now.
Mm-hmm.
So you get very frustrating.
It could, but some of it comes down to addressing why are they doing that. So the behavior and what's causing that. What else, Dim?
Wouldn't it help with being able to identify toxicity faster?
Possible.
Be easier to switch drugs, maybe.
Maybe.
New.
I kind of feel like the opposite. I think that like not having to take your patient at their word or like assume that they're lying, like you would have confirmation. You wouldn't have to, like, you say you're taking it, but I don't, you know, it would kind of take the guesswork out of it. So in a way, I think it could be frustrating, but in another way of looking at it, it could just kind of take some of the unknown out of it. So you could really tell, is it truly not working or are they not taking it?
True, because at this point, we can only take the patient's word.
Right, exactly.
And we can look at refill history. If they're smart enough, they can take the drug and toss it.
Yeah.
Or they can just refill on time. You have no idea. So what's the downside from what's the other side of it? What about from the patient's side?
Big brother.
It is, you know, the things that worry me is now if you don't take your drug, what then can the insurance say about you? You know, then it puts much more onus on the patient because now you have some verifiable way of telling.
Well, what about like the schizophrenics, like the paranoid personalities who are on these medications?
That's
Could you
true.
just imagine, like,
That's true. I don't know. You know, from the standpoint of our provider, I can see helpful, but you know, on the other side, I don't know. I don't know if I want somebody knowing that much about them.
Is this something that society could force people to do? I mean, right now, is this something that you could make someone
Force? I don't know that you could force them.
but you could incentivize them?
You could probably incentivize. But there's all kinds of drugs that are looking at this, not just seizure, not just psychiatric.
I personally would love it because I can never remember taking it on its own.
well, that's like,
My life is too
they have a, Freestyle just came out with like a patch that continuously monitors your blood sugars.
Right,
So,
right. And Medicare will now pay for a lot of those too,
Yeah.
so. Okay, we will pick it up this afternoon when I come back at 3. No, Dr. Britton said he thought he'd be done a little bit early, so about 2:30 we'll probably pick up the acute depressant. And then we'll talk about lithium and antipsychotics. Have a nice day.